Welcome back to the deep dive. Today, we are tackling a fascinating and I would say deceptively complex region of human anatomy.
It really is.
We're synthesizing the chapter on the lower urinary tract and male genital system from, well, the heavy hitter Robbins and Cochrane pathologic basis of disease.
And we're also pulling in those crucial mechanistic insights from Underwood's pathology to really, get at the why.
Exactly. And the central concept, the big idea that kept jumping out at me from both texts, is this idea of constrained anatomy.
That's the perfect phrase for it. It's a part of the body that's just defined by that. You have these absolutely vital systems, waste disposal on one hand and reproduction on the other, and they're operating in incredibly tight quarters.
Sharing the same plumbing, essentially.
They're in the exact same plumbing. And that constraint is everything. I mean, small changes have massive consequences.
Constrained is absolutely the operative word. As I was going through the source material, it struck me just how much of the pathology here is, well, it's a physics problem. It's fluid dynamics meeting structural resistance.
Right. It's a story of flow and obstruction.
You have the urinary system, which is all about low-pressure storage and then high-flow release.
And then you have the genital system, which relies on these incredibly complex hormonal signals and, precise cellular differentiation. And as you said, they share the exact same exit route.
Which is just asking for trouble from an engineering perspective.
It really is. And that's the central tension of this whole deep dive, I think. The concept of flow versus obstruction. Whether we're talking about the ureters, the bladder, or the prostate, the disease process almost always kicks off with some kind of impediment to passage.
And when the flow stops, the pressure builds.
The pressure builds. And when pressure builds up in biological tissues, the architecture has to change. It has to adapt to survive.
And that adaptation, that change in architecture is often where the pathology really becomes visible to us.
Precisely.
So before we dive into all the granular details, and there are a lot, from molecular genetics all the way to, gross tissue architecture, let's set the stage for you. We are not just listing diseases today.
No, this is about building a conceptual map. We want to help you move beyond the rote memorization of this disease causes this symptom. We really want to get at the why.
Why does the bladder wall get thick? Why does prostate cancer have this weird affinity for bone?
And why do certain testicular tumors look the way they do under a microscope? It all comes back to mechanism.
So our roadmap for today is pretty clear. We're going to start with the plumbing itself, the ureters and the bladder, and really dig into the physics of obstruction.
Then we'll move on to the fire, so to speak, the inflammatory landscape of this region.
From there, the prostate. This is a massive topic. We have to cover both its benign enlargement, BPH, and its malignant transformation.
And finally, we'll round it out with the rest of the male genital tract, looking specifically at the penis and the testes.
And for anyone listening who's in the field, or if you're using this to help you study, please remember what this is. This is our interpretive synthesis.
Right. We're pulling out the pearls, we're connecting the dots, but there is absolutely no substitute for reading the actual texts. Open Robbins. Look at those histology plates, look at the diagrams in Underwood. This discussion is the scaffold. The text itself is the building.
A perfect way to put it. So let's begin where the urine begins its final journey. Let's talk about the ureters.
Okay.
To the uninitiated, these are just, tubes, massive conduits connecting the kidney to the bladder. But Robbins makes it really clear that their location, the retroperitoneum, is, well, a dangerous neighborhood.
A very dangerous neighborhood. The retroperitoneum is distinct from the main abdominal cavity. It's not this open space. It's a tight, fatty, connective tissue compartment that's plastered up against the posterior body wall.
So the ureters aren't just floating free.
Not at all. They're embedded in there with major blood vessels, nerves, lymph nodes. And this makes them incredibly vulnerable to extrinsic compression. Things growing around them can just squeeze them shut.
Which brings us to a specific pathology that stood out to me from this section, something called retroperitoneal fibrosis. Older texts might have called it Ormond disease.
Right, and we're seeing a real shift in how we understand the mechanism behind this.
What's the new thinking?
Well, historically, it was this big mystery, this idiopathic fibrosis that would just appear and strangle the ureters. But now, we're increasingly recognizing it as part of the IgG4-related disease spectrum.
Oh, interesting. So it's a systemic condition.
It's a systemic autoimmune process. You get these plasma cells that are secreting a specific type of antibody, IgG4, infiltrating the tissue. And for reasons we don't fully understand, this triggers massive sclerosing fibrosis, a dense scar.
It's like it encases the ureters in concrete.
That's a great visual for it. And because the ureter isn't just a passive drain pipe, it's a muscular tube that relies on peristalsis, on rhythmic waves of contraction to push urine down.
Right, it's not just gravity.
Exactly. So that encasement, that concrete, it stops the flow even if the lumen itself isn't totally pinched shut. It just halts the wave.
Which brings us to the internal checkpoints, the bottlenecks. The classic one is the ureter-pelvic junction, or the UPJ. This is where the big collecting funnel of the kidney, the renal pelvis, narrows down into the ureter.
And this is by far the most common cause of significant hydronephrosis in infants and children. And the pathology here is really subtle. It's usually not a scar, not a stricture in that sense.
So what is it?
It's a functional discontinuity. The smooth muscle bundles at that junction are just disorganized. They're not arranged in the proper spiral orientation that's needed to conduct the electrical signal for a contraction.
So it's in a peristaltic segment. It's a physiological dam.
Correct. The wave of peristalsis comes down the renal pelvis, it hits that disorganized spot, and the wave just dies, and the fluid backs up.
Which is the perfect lead-in to the concept of hydronephrosis. Now, Underwood does a fantastic job explaining the mechanics here, but I really want to get into the physics of it, because it's not just water in the kidney. It's a pressure transfer problem.
It's a closed hydraulic system. That's how you have to think about it. If you block the ureter anywhere along its length, the pressure starts to rise in the renal pelvis.
And Laplace's law comes into play here, doesn't it? The wall tension.
It does. Laplace's law tells us that wall tension increases as the radius of a vessel increases. So as the pelvis dilates from the pressure, the tension on its wall goes up and up. But the kidney is encapsulated. It can't just expand indefinitely.
It's in a tough, fibrous bag, so the pressure has nowhere to go but inward, into the renal parenchyma itself, into the functional tissue of the kidney.
And this is the absolute critical point that both texts make.
Mm.
The damage to the kidney isn't just from mechanical crushing, that's part of it, but the real killer is ischemia.
Like a blood flow.
Exactly. The pressure in the collecting system in the tubules eventually rises so high that it exceeds the venous pressure in the kidney, the pressure in the veins.
So blood can't get out.
Blood can't get out, which means fresh, oxygenated arterial blood can't get in. The entire microvasculature of the kidney gets compressed.
And you get renal atrophy. The kidney shrinks, not because it's being squished, but because it's being starved of oxygen over a long period of time.
Precisely. The tubules dilate, the specialized cells flatten out and die. You get chronic inflammation setting in, and eventually you're left with just a thin, paper-like shell of a kidney.
A functional organ turned into a fluid-filled sac.
And it can happen so silently, can't it? If the other kidney is working fine, the patient might not know anything is wrong until most of the function is gone.
A truly silent process. Okay, so moving down the stream, we hit the bladder. The bladder is fascinating. It's arguably the most abused organ in the body in terms of just pure mechanical stress. It fills, it stretches to incredible volumes, it empties, it collapses over and over, thousands of times a year.
It's an engineering marvel, really.
Mm-hmm.
The lining, the urothelium, those transitional cells, they're specifically designed to slide past one another as the bladder fills.
And on the very surface, you have what are called umbrella cells.
Right, and they're literally specialized to be waterproof. They have these coatings called uroplakins on their surface that form these rigid, impermeable plaques on the cell membrane. It's a biological Gore-Tex.
Preventing the toxic, concentrated urine from leaching back into the blood.
That's its job. And then you have the engine of the whole system, the detrusor muscle, the muscularis propria. That's what provides the force for emptying.
But when that elegant system faces obstruction, and let's use the classic example, an enlarged prostate, the adaptation is just dramatic. The detrusor muscle undergoes hypertrophy.
It's the same principle as lifting weights, as we said. The muscle is constantly working against a high resistance, so the individual muscle fibers enlarge. They get bigger and stronger.
But in the bladder, this isn't a nice uniform thickening. The muscle bundles separate and become these very prominent, coarse bands. This is what we call trabeculation.
Yes, the textbook description is that the inside of the bladder wall starts to look like a basket weave. You can see these thick cords of muscle.
And while the muscle itself is getting stronger, the wall in between those muscle bundles, the little crypts, that part gets weaker.
Right, it's a point of structural weakness.
Yeah.
And if the pressure inside the bladder remains high, the mucosa, the inner lining, can get pushed out between those muscle fibers.
Creating a diverticulum. It's a little pouch.
A false pouch, to be precise, because it lacks the muscle layer. It's just mucosa and a thin layer of connective tissue. And this is a huge clinical problem.
Why is that?
because there's no muscle in the wall of the diverticulum. It can't contract. So when the patient voids, the main bladder empties, but the diverticulum stays full of urine.
Stasis.
Stasis. And as we always say in pathology, stasis is the mother of all evil. It's the mother of infection and stone formation.
And, as Robbins points out, it's also a perfect hiding place for cancer. High-grade tumors can arise in these diverticula, and because the wall is so thin, there's no muscle layer to get through, they can invade the surrounding fat very, very quickly.
It becomes a diagnostic blind spot and really a therapeutic nightmare.
Okay, let's shift gears slightly from the physics of pressure to the biology of inflammation. Let's talk about cystitis. Now, we all know the basics, the classic triad of frequency, urgency, and dysuria, or pain on urination.
Right. And we know the usual culprits. It's overwhelmingly bacterial, most often E. coli and other coliforms from the gut.
But I want to dig into some of the weird stuff. The chronic metaplastic responses that the textbooks highlight when the bladder is under long-term inflammatory stress.
This is where the urothelium really shows its instability, the very plastic tissue.
Mm-hmm.
Under chronic stress, say from a long-term indwelling catheter or just constant recurrent infections, the urothelium changes its identity. It undergoes metaplasia.
It can turn into a different type of epithelium altogether.
Exactly. It can turn into a tough, stratified, squamous epithelium, like your skin.
Mm-hmm.
Or, and this is where it gets really interesting, it can undergo glandular metaplasia.
This is cystitis cystica and cystitis glandularis, correct?
Yes. In both, you get these nests of urothelium that drop down from the surface into the underlying connective tissue, the lamina propria. In cystitis glandularis, the center of these nests undergoes metaplasia and starts to look like intestinal epithelium. It forms goblet cells that produce mucin.
So the bladder is trying to become a gut to handle the irritation.
In a teleological sense, you could say that it's trying to protect itself by coating the surface with mucus.
Mm-hmm.
But clinically, it's really important because on a biopsy, these glandular structures can sometimes be confused with adenocarcinoma.
Okay, then there's malakoplakia. This is one of those conditions that seems to pop up on every pathology exam. You always hear about these soft yellow plaques visible on the bladder wall.
Malakoplakia is just a fascinating intersection of immunology and microbiology. It typically happens in patients who are immunosuppressed in some way.
And what's the mechanism?
The macrophages in the bladder wall engulf bacteria, again, usually E. coli or Proteus, but they have a defect in their phagocytism function. They can't properly digest the bacteria they've eaten.
The cellular garbage disposal is broken.
Perfectly put. The bacteria die, but their calcium and iron-rich skeletons, their debris, remains inside the macrophage. Over time, these mineral deposits build up in these beautiful concentric layers inside the cell.
And those are the Michaelis-Guttman bodies.
Those are the Michaelis-Guttman bodies, and they are pathognomonic. If you see those little basophilic target-like inclusions inside a macrophage in a bladder biopsy, it's malakoplakia, full stop.
It's essentially a fossil record of failed bacterial digestion.
It is. It's a chronic granulomatous response to undigested bacterial junk. It just shows you how dependent we are on the microscopic machinery inside every single one of our immune cells.
And before we leave the bladder, we absolutely have to tackle neoplasia, bladder cancer. Robbins presents this two-pathway model that I found incredibly clarifying. It suggests there isn't just one road to bladder cancer.
This is absolutely crucial for understanding the disease, both for prognosis and for treatment. We used to think of it as this simple linear progression, but we now know, molecularly, there are two very distinct tracks.
Okay, let's start with track 1. This is the papillary pathway.
Right. So these are the tumors that grow as these exophytic, finger-like or frond-like structures out into the lumen of the bladder. You can see them on cystoscopy.
And they tend to be low grade.
They're usually low grade. And genetically, they're often driven by activating mutations in genes like FGFR3 or RAS. They have a very high rate of recurrence. They're a real nuisance for the patient and the urologist, but they rarely invade deeply or metastasize early on.
They're the surface problem. But then there's track 2.
Track 2 is the flat, invasive pathway. And this is a much more sinister beast. This often starts as carcinoma in situ, or CIS.
And visually, this can be very subtle.
Extremely subtle. On cystoscopy, it might just look like a velvety red patch on the bladder wall, but molecularly, it's a monster. These tumors are driven by loss-of-function mutations in the great guardians of the genome, TP53 and RB.
So even though it looks flat and maybe even luminescent, the cells are high-grade and aggressive from day one.
From the very beginning. They have a very high propensity to invade down into the muscle layer of the bladder, the muscularis propria. And once they hit the muscle, the prognosis drops significantly because that's where they gain access to the lymphatics and the blood vessels to spread.
This distinction is why urologists get so nervous about a patch of flat erythema in the bladder. It could be simple inflammation, or it could be high-grade CIS that's just waiting to invade.
And it completely explains why we treat them so differently. You use topical immunotherapy like BCG for CIS, you use transurethral resection for the papillary tumors, and you have to consider radical cystectomy for muscle-invasive disease. Different biology, different treatment.
Okay, let's move from the reservoir to the gatekeeper of the stream, the prostate.
Ah, yes. The organ that probably generates more business for urologists and pathologists than almost any other.
And we have to start with the anatomy, but not just any anatomy, the zonal anatomy. You simply cannot understand prostate pathology if you think of the gland as just a uniform ball of tissue.
No, you'll be completely lost. It's a collection of distinct glandular zones, each with its own distinct biological behavior. You have the transition zone, which is the small inner part that directly surrounds the urethra.
Like a collar.
A collar, exactly. Then you have the big peripheral zone, which makes up most of the posterior and lateral aspect of the gland. This is the part you feel on a rectal exam.
And there's a central zone, too.
Yes, a smaller central zone that surrounds the ejaculatory ducts as they pass through. But for our purposes, the transition and peripheral zones are the main players.
Because diseases have preferences for these zones.
They absolutely do. Benign prostatic hyperplasia, or BPH, is almost exclusively a disease of the transition zone.
And prostate cancer, the classic adenocarcinoma, is overwhelmingly a disease of the peripheral zone. More than 70% of them arise there.
And that single fact explains almost everything about their different clinical presentations.
Let's unpack BPH first. It's called benign, but the morbidity it causes in aging men is massive. The texts dive deep into the hormonal drivers, and it's not just testosterone, is it?
No, testosterone is really just a pro-hormone in the prostate. It circulates in the blood, it enters the prostatic stromal and epithelial cells, and inside those cells it gets converted by an enzyme.
5-alpha reductase.
Specifically type 2 5-alpha reductase, and it converts testosterone into dihydrotestosterone, or DHT.
And DHT is the high-octane fuel for the prostate.
It's the superfuel. It binds to the androgen receptor with something like 10 times the affinity of testosterone itself. This activated receptor complex then goes to the nucleus and drives the transcription of a whole host of growth factors, things like FGF and TGF-beta.
And this interaction between the stroma, the connective tissue framework, and the epithelium, the glands, is absolutely key. Robbins mentions that early BPH is actually mostly stromal proliferation.
Yes, that's a critical insight. If you look at the earliest BPH nodules, they are solid nodules of stromal cells. The connective tissue proliferates first. It's only later that these stromal cells start sending paracrine signals to the adjacent epithelium, telling it to proliferate. So then you get the glandular nodules that make up the bulk of the disease we see clinically.
So it's a stromal-driven process, with the epithelium as a secondary responder.
Correct. And because this whole process is happening in the transition zone, right around that urethral collar we talked about, it doesn't take much growth to cause a problem. It compresses the urethra into a slit-like orifice,
leading to all those bladder changes we already discussed. The hypertrophy, the trabeculation, the diverticula, it's all connected.
It's a perfect chain of events. And understanding this hormonal pathway is what gives us our treatments.
Exactly. It explains the pharmacology. We use 5-alpha reductase inhibitors like finasteride to block that conversion of testosterone to DHT.
By cutting off the DHT supply, you can actually shrink the glandular component of the prostate over time.
But that's not the only class of drug. We also use alpha blockers.
Right, like tamsulosin. Those don't shrink the prostate at all. They target the alpha-1 adrenergic receptors on the smooth muscle cells within the prostate stroma. They just relax the collar. They improve flow immediately, but they don't change the underlying disease process.
Two different mechanisms for the same clinical problem. Okay, let's pivot now to the heavy hitter. Prostate adenocarcinoma. As you said, the most common non-skin cancer in men.
And it's a disease of so many paradoxes. It can be an incredibly indolent, slow-growing condition that you will die with, not of, or it can be a rapidly fatal metastatic disease. And figuring out which is the central challenge.
We've established its preferred location is the peripheral zone. And this is crucial for screening, isn't it?
It's everything. Because it grows in the posterior periphery, it grows away from the urethra initially, so it doesn't cause urinary symptoms until very, very late in the game. But it is palpable on a digital rectal exam. The DRE is specifically designed to feel that posterior surface.
And then, of course, there's PSA, prostate-specific antigen. We need to be very nuanced here. As the book stressed, PSA is organ-specific, but it is not cancer-specific.
Right. PSA is a normal protein. It's a serine protease whose job is to liquefy the seminal coagulum. A tiny amount of it normally leaks into the bloodstream.
And cancer disrupts the normal architecture.
Cancer destroys the basement membranes and the normal glandular structure, allowing much more PSA to leak into the blood. But so does BPH, which is a massive increase in the number of PSA-producing cells. So does prostatitis, inflammation. Even a DRE or ejaculation can cause a temporary bump.
So a single high PSA value is a flag, not a verdict.
Exactly. It's a risk stratification tool. That's why we look at things like PSA velocity, how fast is it rising over time, and PSA density, which is the PSA level divided by the volume of the prostate gland. Those help distinguish a cancerous signal from the noise of BPH.
Let's get into the genetics for a moment. The source material highlights a really fascinating fusion gene that's common in prostate cancer, TMPRSS2-ETS.
This was a landmark discovery. It's present in about 40 to 50% of prostate cancers. What happens is you get a chromosomal rearrangement, a translocation, that fuses the promoter of one gene, TMPRSS2, with an oncogene from the ETS family, usually ERG or ETV1.
And the key thing about the TMPRS2 promoter is that it's regulated by androgens, by testosterone.
Precisely. So, as you said before, the cancer has effectively hot-wired the system. It has connected the gas pedal, the ERG oncogene, directly to the ignition switch that gets turned on every time the cell sees testosterone.
So every time there are normal androgens present, it's driving oncogene expression and proliferation.
That's it. It explains so beautifully why prostate cancer is so fundamentally an androgen-dependent disease.
And it's why androgen deprivation therapy, chemical or surgical castration, is the cornerstone of treatment for advanced metastatic disease. You're taking away the fuel.
You're taking your foot off the gas pedal.
Now, grading. We can't talk about prostate cancer without talking about the Gleason system. But there's been a big shift recently, and modern texts are moving towards what are called grade groups. Why the shift?
The Gleason system, which has been around for decades, is brilliant but has some quirks. It's based entirely on the architecture of the glands, not how ugly the individual cells look. Grade 1 is perfect, well-formed glands. Grade 5 is just sheets of cells with no glands at all.
And you add the two most common patterns together to get a score, like 3 + 4 = 7.
Right. But there was a big problem, particularly at the low end. Patients would get a biopsy report that said Gleason score 6, which is 3 + 3. They would hear cancer and score 6 out of 10, and they would panic and demand aggressive surgery or radiation.
Even though we now know that pure Gleason 6 cancer is incredibly indolent.
Exactly. It has almost zero metastatic potential. It's a disease that is perfectly suited for active surveillance. So the new ISU grade group system was created to fix this. It relabels Gleason 6 as grade group 1, Gleason 3 + 4 or 7 as grade group 2, and so on.
It's a psychological reframing.
It's a psychological reframing to de-escalate anxiety and encourage less aggressive management for low-risk disease, because the side effects of treatment incontinence erectile dysfunction are significant. Architecture really is destiny in the prostate.
One specific mechanism of spread that Robbins highlights is perineural invasion.
Yes, this is a classic finding on a prostate biopsy. If you look at a slide, you will very often see malignant glands completely encircling a nerve fiber.
It's not just random spread.
No, the cancer seems to use the nerve sheath as a low-resistance highway to escape the confines of the prostate gland. It's a classic sign of malignancy and a route for extraprostatic extension.
And if it does leave the prostate and metastasize, it has a strong predilection for bone. But these metastases are unique. They aren't lytic. They don't eat holes in the bone like, say, multiple myeloma does. They are osteoblastic.
That's right. For reasons that are still being worked out, the prostate cancer cells in the bone secrete factors like endothelin-1 that stimulate the osteoblasts, the bone-building cells.
So the body starts laying down new but very disorganized and brittle bone.
Exactly. On an X-ray or a CT scan, the affected bones, especially the vertebrae of the lumbar spine, look incredibly dense and white. The classic term is ivory vertebrae.
And it's a very painful sclerotic process.
Very much so. It can lead to spinal cord compression and pathological fractures.
Let's move down to our final section, the penis and the testes. The penis is often overlooked in general pathology discussions, but there are some really critical associations here that mirror what we see elsewhere in the body.
Yes, specifically when we're talking about squamous cell carcinoma, just like in the cervix and the oropharynx, we see two distinct pathogenic pathways.
The HPV pathway and the non-HPV pathway.
Correct. The first pathway is driven by high-risk human papillomavirus, usually strains 16 and 18. The virus produces the oncoproteins E6 and E7.
Which famously knock out P53 and ARB, the two main tumor suppressors.
And this leads to a type of cancer that is often seen in younger men and often starts as a precursor lesion called Bowen disease, which is essentially carcinoma in situ.
And the non-HPV pathway. This is more linked to chronic inflammation.
Yes, specifically to conditions like lichen sclerosus, which in the genital tract is also called Balanitis erotica obliterans. This is a chronic atrophic inflammatory condition. The epidermis thins out, the underlying dermis becomes scarred and fibrotic.
And one of the major consequences of this scarring is phimosis, a tightening of the foreskin so it can't be retracted.
And that phimosis creates a closed anaerobic environment. Smegma, which is just desquamated epithelial cells, can accumulate. You get chronic irritation and inflammation. And that decades-long cycle of injury and repair is what drives the P53 mutations that lead to cancer in older, uncircumcised men.
Fascinating. Okay, finally, the testis. We have to discuss germ cell tumors. This is the main type of cancer in young men aged 15 to 35.
It is. And the big unifying pearl here from a genetic standpoint is that almost all germ cell tumors, regardless of what they look like under the microscope, share a specific abnormality. And that's a chromosome of the short arm of chromosome 12, or isochromosome 12p.
Which strongly implies a common origin.
It strongly suggests they all stem from a common precursor lesion, which we call germ cell neoplasia in situ, or GCNIS. From that precursor, they can then diverge down two main pathways, into seminomas or into non-seminomatous tumors.
Let's differentiate those for you listening. Seminoma.
Seminoma is the most common type. It's composed of cells that resemble the primitive germ cells of the early embryo. Under the microscope, you see these large, uniform cells with clear cytoplasm. It's full of glycogen arranged in sheets that are broken up by these delicate fibrous septa containing a lot of lymphocytes. The classic description is that they look like fried eggs.
And the crucial clinical point is that they are excludedly sensitive to both radiation and chemotherapy.
Highly, highly curable. Even when they have metastasized, the prognosis is generally excellent.
The non-seminomas, on the other hand, are the wild ones. This category includes things like embryonal carcinoma, choriocarcinoma, and yolk sac tumor.
These are much more aggressive. They tend to metastasize earlier, often through the bloodstream, and they're defined by their differentiation into all sorts of weird and wonderful embryonic and extraembryonic tissues.
Give us an example.
Well, embryonal carcinoma forms these ugly, primitive-looking glands. Choriocarcinoma is fascinating. It differentiates into cells that mimic the placenta, the syncytial trophoblasts and cytotrophoblasts, and as a result, it secretes huge amounts of HCG, the pregnancy hormone.
And yolk sac tumors.
Those are the most common testicular tumor in infants and young children. The classic histologic finding here is the Schiller-Duval body.
What is that?
It's a microscopic structure that looks a bit like a primitive glomerulus. You have a central blood vessel that's surrounded by tumor cells, all sitting within a cystic space. And clinically, these tumors secrete alpha-fetoprotein, or AFP.
So these tumor markers, AFP from yolk sac tumors, HCG from choriocarcinoma, are absolutely critical for diagnosis and for monitoring treatment.
Absolutely. If you treat a patient with a non-seminoma and their AFP or HCG level doesn't drop back to zero, you know you've missed something. There's residual disease somewhere.
We can't finish up without mentioning a non-neoplastic emergency. Testicular torsion. This is a vascular catastrophe, but there's often an underlying anatomical predisposition, isn't there?
There is. It's called the bell clapper deformity. Normally, the testis is firmly anchored to the posterior wall of the scrotal sac by its mesentery.
Okay.
In some individuals, the tunica vaginalis, the covering of the testes, completely encircles the testes and the lower part of the spermatic cord. This means it's not anchored, and it can swing freely on the cord like a clapper inside a bell.
And so it can twist on its own vascular pedicle.
It can. And when it twists, the thin-walled veins in the spermatic cord are compressed first. The thick-walled arteries keep pumping blood in, but the venous blood can't get out.
So the testes just engorges with trapped blood.
Massively.
Yeah.
It becomes a hemorrhagic infarction. It turns dark, purple, and then black.
And the saying is, time is testis.
It is. You have a window of about 6 hours from the onset of pain to surgically detorse it before the germ cells, which are very sensitive to hypoxia, die irreversibly.
A true surgical emergency. So we have traversed the retroperitoneum, we've squeezed through the prostate, we've navigated the bladder, and ended up in the scrotum. If we step back and try to synthesize all of this, what are the big overarching themes that you want our listeners to take away?
For me, it all comes back to that initial idea, constrained passage. every single major pathology we've discussed. The urethral stone, the BPH nodule, the urethral stricture, the phimosis, it creates disease because it violates the principle of free flow within a confined space.
And the consequences are felt upstream. The kidney pays the price for the bladder's failure to empty, which is caused by the prostate's obstruction.
It's the concept of the unified urinary tract. You cannot treat the kidney in isolation without knowing what the prostate is doing. It's all one hydraulic system.
And when we think specifically about the prostate, I want to come back to something you mentioned before we started, what you called the prostate paradox.
Right. It's the ultimate irony of male anatomy. The prostate is a small accessory gland. It's arguably non-vital for individual survival. Yet, because of two simple facts, its location wrapped around the only exit for urine and its lifelong sensitivity to hormonal stimulation, it becomes the single greatest source of morbidity in the aging male.
It's a biological design that almost guarantees trouble if you live long enough.
It is indeed. It's a fascinating and frustrating piece of engineering.
Well, there you have it. A journey through the plumbing and the pathology of this incredibly complex region. I really hope this deep dive has given you the conceptual framework to understand these diseases, not just as lists of symptoms and facts, but as logical, dynamic, mechanical, and biological processes.
Go back to the text now. With this map in your head, go look at the pictures of the Schiller-Duval bodies. Look at the architectural patterns of the Gleason grades. Visualize the flow. Visualize the obstruction. It will all make so much more sense.
Thanks for listening. We'll see you on the next deep dive.
Goodbye for now.